vagina. You see that attached to the cervix right there? That's a proximal part, okay, here.
Sorry, can you say that again? My chat.
Can you see the picture? So
Yep.
this is the distal part of the vagina. This is the proximal part of the vagina, that closer to the cervix, okay? So that's what it is, all right.
Thank you.
Oh, not this one. We are not done yet. Let's go back. All right, let's go back to the book. Now, some other diseases, mole. 100% one question in the mole, okay? Always you have one. Now, when it comes to the mole, folks, your task is to differentiate from complete mole from the partial mole. Because when you read a question, you would know it's a mole, folks, okay? So we will see some common features first. Now, these are cystic swelling of chorionic villi and proliferation. That's the idea. These are trophoblastic tissues, okay? Patient comes with vaginal bleeding, emesis. That emesis, throwing up, is very important here. Uterine enlargement more than expected, all these things, folks, okay? Now, hyperemesis gravidarum and early preeclampsia, blood pressure. We will talk about preeclampsia. It is a very sign indication for that, folks, okay? What is hyperemesis gravidarum? It's basically excessive vomiting. Is that clear, folks? The excessive vomiting happens, normally pregnant people vomit a lot on the first trimester, and then it reduces to second trimester, third semester, barely they have it. Why? Progesterone is the reason for vomiting. Progesterone is way high on the first trimester, then a little bit low on the second trimester. Third trimester, it's almost going down, okay? So progesterone causes vomiting, folks, okay? That's important. Now here, talking about the two moles, complete and partial mole. Now, if you see the complete and partial mole, how to differentiate? Look at this. Complete, it's 46 chromosome, 23 and 23, right? So one egg and one sperm, 23, 23, that's 46, folks. That's why you get it. And the histology is simply those trophoblastic proliferation. Those are the tissue. Trophoblast has two types, if you remember. Syncytial trophoblast, cytotrophoblast. Okay, those are the two. Now, the way I pick the answer on the exam is by this. The complete mole has no fetal tissue, so no fetal pads, folks. Okay, there is nothing in there. The second thing, the beta HCG is way high. Beta HCG is way high. Beta HCG is way high. On the imaging, we're going to see honeycomb uterus or cluster of grapes. Like, you see that? Those are the things because there's no actual fetal parts. That's why you see those things, folks. That's complete mole. Is everybody clear? Now, let's compare that with the partial mole. Partial mole is 69. So whereas complete 46, this is 69. Why? There is 2 sperm and 1 egg. So that's 23, 23, 23, right? So that's why you get the number 69, folks, okay? So that's that. The best part to get the right answer, fetal parts. When the question tells, they were saying there will be some samples of fetal tissue. The minute you see the fetal parts, that's it. Fetal parts is the key. I'll show you a question. And that's the most important. That's how you differentiate complete and partial. And complete has a risk of choriocarcinoma, whereas partial is not. Everybody clear, folks? So those are the two types of mole. Now, let's talk about choriocarcinoma, since it can be a result from the complete. It's a rare malignancy of the trophoblastic tissue. I mentioned those two tissues. Those are cytotrophoblast and syncytial trophoblast. Most commonly occurs after an abnormal pregnancy. That's where this is. And presents with abnormal uterine bleeding, HCG-mediated sequelae, dyspnea, and hemoptysis because it's spread to the lungs. Okay, this is important. The minute you have dyspnea and hemoptysis, it goes to the lung. Through the blood, it goes to the lung, folks, okay? And we have to give methotrexate to treat if we can, but that's choriocarcinoma. Is everybody clear, folks? Now, let's quickly see that question. We have it here. Take a look at this question. So when you see a 16-year-old girl comes to the emergency department with vaginal bleeding, her last menstrual period was 12 weeks ago. She is sexually active and does not use contraception. Patient had a miscarriage that required D&C. Okay. Now, transvaginal ultrasound demonstrate an intrauterine gestational sac without fetal cardiac activity. So that means it is a mole the minute you don't see a cardiac activity. D&C is performed, it shows fetal tissue. So the minute you see the word fetal tissue, what mole is that? That's a partial mole. Is that clear, folks? That is your partial mole. That's how easy to pick that up, folks. Okay. Now, that's the answer. Let's try this one. What's the diagnosis? A 41-year-old woman comes to the office after a positive home urine pregnancy test. Her last menstrual period was 12 weeks ago. For the past month, the patient has had increasing nausea. She vomits several times a day and has difficulty keeping any food down, so that she's vomiting a lot. Okay. The patient has 3 children, all born at term via C-section. On this visit, ultrasound demonstrate echogenic intrauterine tissue without an amniotic sac. So that's almost like a mole. There's no amniotic sac. Multiple bilateral ovarian cyst. Hydrovilli are evacuated from the uterus. Okay, so that's not a fetal part. So that tells you that's a complete mole. Did we get that? There is no fetal part, so that's a complete mole. Now, which of the following should be closely monitored in this patient after the procedure? The answer should be beta HCG. Why, folks? We studied complete mole has very high beta HCG, right? Now, why do we need to monitor it? We want to make sure we removed everything. The only way to confirm that you removed everything to monitor the beta HCG. So we will monitor until it goes down to 0. So let's say I do the D&C today. The patient comes back 2 weeks later and the beta HCG is still there. That tells you we left something in there. Is that clear, folks? So that's why you have to monitor beta HCG until you get there, folks. Okay. So that's that. All right. What's the diagnosis? This patient has choriocarcinoma. Did we get that? It already gone to the lungs, beta HCG side. If chest radiograph shows everything, there you go. That's a proliferation of trophoblast. Okay. Trophoblast is known as syncytial trophoblast and cytotrophoblast. Do not forget that. Everybody clear, folks? All right. That's that. Let's continue. I believe that's the last section of obstetrics here, folks. Okay. Now, hypertension in pregnancy. Now, when we talk about pregnancy, in pregnant period, the landmark of 20th week of gestation, right? 20th week, it plays a major role because a lot of terminologies changes before 20th and after 20th. Does that make sense, folks? Right? So it's almost like psychiatry. You know, in psychiatry, we will see a lot of the name of the disease changes according to the time, but it's the same disease. Same thing. In pregnancy, you should always pay attention to the gestational week. Let's take a look. The only time we could call gestational hypertension if the blood pressure is high that happened after 20th week of gestation. If the patient's blood pressure goes up at, let's say, 16th week, still not considered gestational hypertension. Is everybody clear, folks? So the 20th week is important. No pre-existing hypertension, no proteinuria or end organ damage. Hypertension prior to 20th week of gestation suggests chronic hypertension. So if the patient has high blood pressure before the 20th week, it's just the regular high blood pressure, folks, okay? So that means they had it before, not gestational hypertension. What's the treatment? Antihypertensive, hydralazine. If you watch that video on my farm, cardiac farm, it says, right, hydralazine is the safest to give it, folks, okay? And we have to deliver the baby at 37 to 39 week. Why? Because we have to wait until the lungs to get mature. You cannot try early, folks, okay? We have to give a chance. So that's gestational hypertension. Next, preeclampsia. I will highlight that. That tells you that's a danger when we start. A new onset of hypertension with either proteinuria or end organ damage after 20th week of gestation. What's the difference between that and gestational hypertension? Gestational hypertension, same thing after 20th week, but no proteinuria or no end organ damage. Is that clear, folks? If you have a high blood pressure after 20th week, proteinuria, end organ damage, then we call it preeclampsia. That's all it is. Okay. Onset of preeclampsia less than 20th week gestation may suggest molar pregnancy. This is due to spiral arteries of the placenta. That's one of the reasons they could get endothelial dysfunction, vasoconstriction, any of those things. They're not going to ask you any of this. What they're going to ask you, the complication. What do you think will be the complication? You should know without looking at it. If the blood pressure is high, it can push the placenta away. So placental abruption, look at that. And some other issues, coagulopathy, renal failure, pulmonary edema, insufficient to the placenta, all these things, folks. Now, two things you have to do. The minute mom has preeclampsia, we're going to, of course, treat antihypertensions with medication to reduce. More than that, we have to give IV magnesium sulfate. The IV magnesium sulfate will prevent the seizure that she's about to get it soon. It's a prevention, okay? It's a prophylaxis. What does prophylaxis mean? You are treating before it happens. Is that clear, folks? That's prophylaxis. You have to give magnesium sulfate so she would not get seizure. Now, if I give you the question of preeclampsia and I ask you, what is the definitive treatment? Definitive treatment means the best. Baby comes out. What if the baby is 30th week? No lungs maturation, still the baby comes out. Okay, whether baby developed anything or not comes out. That's a treatment, folks. Okay, so because it's very dangerous. All right. Now, eclampsia. So what's the difference between preeclampsia and eclampsia? Preeclampsia plus seizure is eclampsia. That's all it is. So we just add seizure to it. Preeclampsia with seizure. That's eclampsia. Is everybody clear, folks? Okay. If we would have given magnesium sulfate properly earlier, the patient shouldn't be even going into eclampsia. Okay, but sometimes it does happen fast. Death can happen due to stroke, intracranial hemorrhage, ARDS, and everything, folks. IV magnesium sulfate. Now, keep in mind, when we give IV magnesium sulfate, it always prevents the future seizure. It will not cure the current seizure she is having it. For that, you have to give anti-seizure medication, whatever you do it on a normal patient. An immediate delivery. Again, folks, the kid has to come out. Okay, so that's eclampsia. Are we clear with this?
But anyways, preeclampsia doesn't have, like, they won't be getting seizure, right?
They won't. No.
Why?
So that's why when they have preeclampsia, if you give magnesium sulfate, most of the time they don't. But what happens is sometimes they develop preeclampsia very shortly before you even administer, they will have eclampsia. We cannot tell how fast it can happen. That's that. Okay. Now, let's say a patient comes to the hospital. She's pregnant. She came to the clinic because she felt headache. And we found out she's preeclamptic. She doesn't go home. She gets admitted to the hospital. Okay. Preeclampsia get admitted, folks. Okay. Now, next. HELP syndrome. It is a preeclampsia with some thrombotic microangiopathy of the liver. So it's a problem with the liver, red blood cell breaking down hemolysis, liver enzymes are high, low platelet. It's a group of disorders put together. We call this HELP syndrome, folks. It may occur in the absence of hypertension or proteinuria. You don't have to have a high blood pressure or proteinuria. It can happen. Blood smear shows schistocytes. That's a broken red blood cells. This was asked once on a question. What could be the complication of HELP syndrome? The answer is the rupture of hepatic subscapular hematoma. When people have HELP syndrome, that could be a complication. It can rupture. When they rupture, severe hypertension and possibly DIC. Okay. So whenever they have a HELP syndrome, immediate delivery, folks. Okay. Anything to do with the blood pressure, the baby comes out. Is everybody clear with that? All right. So that's HELP syndrome. Okay. These are high yield. Now, there's something called supine hypotensive syndrome. What is it called? It's also called aortocaval compression syndrome, seen at more than 20th week of gestation. If you see pregnant women, usually they don't sleep on a supine position. They always turn to the side, because if they sleep on the supine position, they have this supine position that causes compression of the abdominal aorta and IVC, because when they lay down, the uterus is just literally sitting on that, right? That will cause, by gravid uterus, decreased placental perfusion and also decreased venous return to the heart. So they feel uneasy. So that's why they always sleep on the right side or left side, folks. Okay. See, it says it's relieved by lateral decubitus position. So whenever they change the side, it helps. So that's it. These are the most important. And the last one is just the statistics. Okay. You don't have to memorize this. In US, endometrial cancer is more common than ovarian and then cervical. That's the order. Cervical cancer is more common worldwide, but not in United States, because here we give vaccine for HPV, right? We get the vaccine, it's called Gardasil, so people don't have that issue. So that's an incident. But let's talk about prognosis, which means which cancer is worse and which one is better. Now you see, folks, cervical cancer has become to a point nowadays, it's like simple. They treat it without any issue. Okay, it's so easy to treat. And then followed by endometrial. The worst cancer, can somebody get it, is ovarian. Most of the time, ovarian, it is pretty hard. Okay. So what's the name of the GI disorder that's associated with ovarian cancer? Don't give me preeclampsia. So what GI disorder associated with ovarian cancer? I knew somebody will type Krukenberg. Why do you guys make that mistake all the time? How many times we talked about it? What is Krukenberg tumor? You have a stomach cancer, it's spreading to the ovary. That doesn't mean ovary has their own cancer. Is that clear, folks? So what's the answer? Lynch syndrome. Lynch syndrome associated with endometrial, ovarian, and some other one, right? So always remember, folks, I wanted to get this Krukenberg out of your mind. Krukenberg is like a stomach cancer simply spreading to the ovary. So if I take a sample of ovary, I will see some gastric tissue. That's it. Does the patient has ovarian cancer? No. Okay. So, but when people have Lynch syndrome, they could have ovarian cancer. That means the patient has two cancer at the same time. Is that clear, folks? Whereas Krukenberg tumor is only one cancer. It's metastasis spreading to it. Okay. Careful, folks. Lynch syndrome. Okay. So that's that. Hertzberger. All right, folks. Now, that's gynecological tumor. So this concludes our obstetrics part. Now what we have left with is gynecological tumor, folks. Okay. Now, I'm going to stop here. We're going to go back to renal and finish off the pharmac and stuff. Okay. And then we'll continue this tomorrow. Okay, go to this page. Now, let's go here. Page 631. We're going to talk about mannitol first. Mannitol is an osmotic diuretics, right? So what it does, it increases serum osmolality, which fluid shift from interstitium to intravascular space, increase urine flow. So basically this medication helps to excrete fluid, okay? It helps to excrete fluid. By excreting fluid, you could reduce the intracranial pressure and intraocular. Intraocular means inside the eye. So we call glaucoma, right? That pressure is reduced. We could use it for drug overdose or people who has increased intracranial or intraocular pressure, okay? Now, what happens if you give too much? You excrete too much fluid, that will cause dehydration. Makes sense? Okay. So we cannot give it to somebody who's already dehydrated. Now, that's what it says. Contraindicated in anuria. What does anuria mean? Less urinary excretion. If somebody is urinating less, it's a sign of high dehydration. And on those people, you cannot give this. It will make it even worse. Okay. And we cannot give it when they have hyponatremia, pulmonary edema, or any heart failure. So, okay. So the key is anuria, folks. You cannot give fluid to lose when they're already dehydrated. Next, acetazolamide. This is an important medication. Acetazolamide is carbonic anhydrase inhibitor. It causes self-limited sodium bicarbonate diuresis, right? What does that mean? It helps to excrete bicarbonate. It helps to excrete bicarbonate. So technically, when you take acetazolamide, you are not reabsorbing bicarbonate in the PCT. Agree? So can we say acetazolamide medication can cause type 2 renal tubular acidosis? Yes. Now you see why carbonic anhydrase inhibitor makes sense, okay? So that can cause metabolic acidosis, in another word. We use it for glaucoma. We use it on people who has metabolic alkalosis. When they have metabolic alkalosis, we don't want any more bicarb. We want to excrete all the bicarb, folks, okay? Altitude sickness, what does that mean? Remember, motion sickness is considered two different parts. People feel throwing up sick on the sea level versus somebody who's going to mountain. Is that clear, folks? If somebody says, I went to mountain, I started feeling this motion sickness, that means they're about 10,000 to 15,000 feet above, right? That is called altitude sickness. For that, this medication will help. Because why altitude sickness? When they go higher, you are breathing, respiratory alkalosis. That's what the sickness is. If you control it, you are good. If somebody tells you that they went on a cruise and they feel sick, can you give this medication? It won't help, okay? Because when you are in the cruise, you are at the sea level, not high altitude. For that, you want to give scopolamine. Is that clear, folks? All right. And then we could also give it to idiopathic intracranial hypertension. We will talk about that on neurology. Basically, pressure is high inside the brain, so we could help to get the fluid out, okay? Now, this can cause proximal tubular acidosis, as we expect. This is also sulfur drug, so if people are allergic to sulfur, cannot give this. Because it causes alkalosis, you are promoting calcium phosphate storm. Because the urine is alkalotic. Why the urine is alkalotic? All the bicarbonate is in the urine, so it's alkalotic urine, folks, okay? So that's azirazolamide. See, mannitol and azirazolamide, it's not a real kidney medication. It does work on the kidney, but it's something to do with different areas of the body. Now we start the real deal for kidney. Loop diuretics. This should be a review for you guys now, right? What is the normal function in thick ascending loop? Reabsorption of sodium, potassium, 2-chloride. That causes back leak of potassium, which create positive potential, help to reabsorb magnesium and calcium paracellularly. We could block that with furosemide. Furosemide is a very famous medication, folks. It blocks. When they block, what happens? You are excreting all the calcium in the urine. Is everybody clear, folks? All right. Now look at this. When do you use? Just for steps. This is a drug of choice for pulmonary edema. Anytime patient has pulmonary edema, we give furosemide, okay? And we could, of course, use it to any edema, but for pulmonary edema, for sure. And when patient has hypercalcemia, makes sense because it excretes calcium. It can give you ototoxicity, hypokalemia, hypomagnesemia, all this. I would highlight allergy. They are also sulfur drug. I would also write it down. This medication is contraindicated in kidney stone patient, right? So I'll put negative sign for kidney stone history. If somebody had a calcium stone history, you cannot give this medicine. If you give, they will be back at your clinic soon. Okay, so they will get stone if you give. So that's loop diuretics. Is everybody clear, folks? You see, when you know the physiology, pharmacology becomes so easy. Okay, now, let's say I have to give loop diuretic to somebody. I have no other choice, but they are also sulfur allergy. What do? I need to find another medication, similar mechanism of action, but no sulfur group. That's your ethacranic acid. Ethacranic acid is exactly same as everything else, except no sulfur group. So no difference, okay? It is very similar to it, but we could give it to people who's allergic to sulfur, okay? So that's that. And of course, it's similar to furosemide, but a little bit more ototoxic, but those are reversible, it comes back. So that's loop diuretics. Is that clear, folks?
What is you have a negative and
Oh,
something
you don't give it to kidney stone people. If they had a history of calcium kidney stone, you cannot give that. All right, that's loop. Next, thiazide diuretics. Hydrochlorothiazide is a famous one. Inhibits sodium chloride reabsorption in early DCT. So you are excreting. We use it for hypertension. Why? So you could excrete fluid. Heart failure, we use it. Idiopathic hypercalciuria, which makes sense. If you do not want calcium to be in the urine, we give this medicine because this medicine reabsorbs all the calcium back to the blood. Is that clear, folks? So can we give this to a person who has kidney stone? Yes. So when you give it to kidney stone, it helps because it reabsorbs, folks, okay? Now, this is something I want to keep an eye on it because it can be confusing in the day of the exam. The best word, except sodium and potassium, everything else is high in the blood. Look at this. Only sodium and potassium is low in the blood. Hypokalemia, hyponatremia. Everything else is high because it's all emia, right? All this. And you also keep in mind, if this is high in the blood, it has to be low in the urine. Is everybody clear, folks? Okay. If I ask you, when I give thiazide to a patient, what happened to the glucose in the urine is going to be low. Because why? It's hyperglycemia, so it has to be hypoglycuria. Okay, so opposite. So the best thing, remember sodium and potassium is low in the blood, everything else is high. That's thiazide. Potassium sparing diuretics. All these diuretics, folks, right? Spironolactone, amiloride, Triamcinolone, all this medication. They help to block aldosterone receptor, right? These are literally aldosterone receptor antagonists. Only thing it doesn't do, it does not work on potassium. It keeps the potassium. That's why it's called potassium sparing, folks, okay? So we use it for hyperaldosteronism, which makes sense. When people have high aldosterone, we don't want that to work. When people have low potassium, we give this because it preserves the potassium in the blood. Okay. Now, I mentioned this in GI. Spironolactone is a drug of choice for ascites. NBME 25 or 26 has simple question: which of the following drug is given to ascites? People miss it. It's spironolactone, folks. Okay. That's a drug of choice for it. Okay. Now, we could do that. Side effect. Because it doesn't excrete potassium, sometimes they can accumulate more potassium that become hyperkalemia. That's why it's called potassium sparing, right? So they do not excrete potassium. So when they keep hyperkalemia, it can lead to arrhythmias and stuff, right? So the potassium is bad. It can cause QT prolongation, isn't it, folks? And if you have increased QT prolongation, you are predisposed to torsades. What's the definition of QT interval? Type it up. I want the definition of QT interval physiology. Very good. From the beginning of the ventricular contraction till the end of ventricular relaxation, or another word, ventricular depolarization plus repolarization. Okay, good. All right. So, and the next thing to learn, spironolactone gives you gynecomastia, anti-androgen effect, folks. Okay, and metabolic acidosis. Why? Because it also inhibits hydrogen excretion. So that's potassium sparing diuretics. Is everybody clear? Okay. Now, this is a summary. We'll come to that in a moment. Let's finish these two drugs. ACE inhibitors. This is any pill medication is called ACE inhibitors. That tells you when you inhibit the ACE, decrease angiotensin 2. When you decrease angiotensin 2, you are decreasing GFR by preventing the constriction of efferent arteriole. Should make a perfect sense by now. Okay, so it decreases GFR. Okay. Now, of course, there's an increased renin due to loss of negative feedback. Okay, so they will be high in renin because when you have a decreased angiotensin 2, you will have that. Inhibition of ACE also prevent inactivation of bradykinin. We talked about it. You need ACE enzyme to digest bradykinin. Otherwise, what will happen? Bradykinin will accumulate and it will cause cough. Cough is one of the side effects of ACE inhibitor because of bradykinin accumulation, folks. We use this for hypertension, heart failure. What did we say about ACE inhibitor? It prevents the heart remodeling. It's right there. Okay. It prevents the heart remodeling. Anybody has heart failure, they go home with ACE inhibitor. Okay. Now, continuing side effect, cough, angioedema, all these things. And if a patient already has a history of C1 esterase inhibitor, you cannot give ACE inhibitor because there is no one to metabolize bradykinin. Is that clear, folks? All right. Pregnancy cannot take because it's a fetal renal malformation. And this one, we talked about this. We cannot give ACE inhibitor when somebody has bilateral renal artery stenosis because bilateral renal artery stenosis already has decreased renal blood flow, decreased GFR. Giving this will make it even more decrease in GFR. Okay. So if you see here, it's already decreasing GFR, and people with renal artery stenosis bilateral already have decreased, so it will make it worse and renal failure will happen. Is everybody clear, folks? So that's ACE inhibitor. Now, if somebody comes to you and say that, I took ACE inhibitor, I have a cough, I have a side effect. But if you still want to do the same mechanism, we go for receptor blocker, losartan, valsartan. It exactly works like ACE inhibitor, but instead of blocking the ACE enzyme, they are blocking the receptor. So they are not inactivating the ACE enzyme. Is everybody clear, folks? So ACE enzyme is preserved in this patient's preserved, okay? Selectively block binding of angiotensin 2 to its receptor. Effect similar to ACE inhibitor, but it do not increase bradykinin because ACE is there to digest that. The usage is exactly the same, folks, okay? It's exactly the same. Again, it decreases GFR and teratogen. Just remember, receptor blocker and ACE inhibitor is exactly the same except the effect in the bradykinin. Is that clear, folks? That's the only thing. The only reason we have to even consider if they come with the problem of coughing or anything to do with bradykinin. Last one, aliskiren. This is a new medication that is a direct renin inhibitor. When we say direct renin inhibitor, it blocks the conversion of angiotensinogen to angiotensin 1. So no more angiotensin 1, no angiotensin 2, nothing, folks. We could use it for hypertension. Same thing, decrease GFR. If you see, guys, in renin system, it doesn't matter where you block. The end product is decreased GFR. Is that clear, folks? So it's the same thing. And it says contraindicated in patient already taking ACE inhibitor or ARB. Why? They are already taking that, which means that will decrease the GFR. And you give this, it will make it even worse. Everybody clear, folks? So that's the idea, okay? So that's aliskiren. Now, let's go back to this summary. This is kind of summary after you go through the pharmacology, if you really want. If not, you don't, because we pretty much know. I'll show you what it is. Urine calcium. Don't look at the book. Can you tell me a medication that increased the urine calcium? What's the name of the medication that increases the urine calcium? Loop diuretics. That's what you guys are thinking, isn't it? What's the name of the medication that decreases the urine calcium? Thiazide, isn't it, folks? They just put it to you for there. See, increase with loop, decrease with thiazide. It's like a summary for you, right? I usually don't look at it because if you understand each of them, you don't need this. And then they're explaining which medication increases urine sodium chloride. That's all the diuretics. Does that make sense, folks? That's what it is, okay? Which medication increases urine potassium? So these are the things to look at it. But if you understand each of this medicine, I wouldn't be worried about this, okay? The renal pharmacology is relatively easy. It's only a few medications, folks. All right, let's go to the embryology section. I already talked about this. Inferior mesenteric artery of the horseshoe kidney, very important. I just want to talk to you guys here. And I already explained what is vesicoureteral reflex. The next thing I just want to talk about is parasequence, okay? Now, in amniotic cavity or amniotic sac, so let's talk about amniotic fluid actually. What's the normal physiology of amniotic fluid? Amniotic fluid, the fetus, they bring the amniotic fluid and then they urinate through the kidney. Does that make sense, folks? And then they drink it again. So we all have drank our own urine technically. Okay, so that's the effect here, folks. Okay. So that's the normal physiology. There are two medical conditions you get: oligohydramniosis, polyhydramniosis. Oligo means decreased amniotic fluid. If a patient has a decreased amniotic fluid, it's a problem with the kidney, renal problem. Why? The baby have no problem drinking, but they have problem urinating. That's why it's not there outside. Okay. I keep using the word baby, but it's fetus. Okay. You cannot supposed to use the word of baby until they are born, but it's fetus basically. Okay. Now, if the fetus or the amniotic cavity shows increased fluid, that's a GI problem of the fetus. That means the fetus cannot drink the fluid. Is that clear, folks? Okay, we cannot drink. So oligohydramniosis is renal pathology. Polyhydramniosis, GI pathology, like an esophageal fistula. Some of those diseases, folks. Okay, that's the idea. Okay. That's that. So that's oligohydramniosis and polyhydramniosis. Any questions so far? So you understand that. Okay. Now, parasequences, basically, when they have oligohydramniosis, what that tells them? They have no problem drinking, but they have problem excreting. So the amniotic cavity don't have enough fluid. So the fetus face is getting hit by the wall and stuff, right? Compression of the developing fetus, limb deformities, facial anomalies, all these things can happen, folks, okay? Now, the key to remember, anytime you have a renal pathology, it's always linked to pulmonary pathology, pulmonary. So the best way you can remember, if the fetus don't develop kidney, they don't develop lungs. Okay, if they don't develop kidney, they don't develop lungs. You see here, fetal hypoplasia and cause of death. Okay, that's the problem here, folks. Because why? If they don't excrete the fluid, they cannot drink again to get in. They have to aspirate into the lungs. That's what it is, folks. Okay. Now, most of the time, you have to be careful here, folks. Sometimes what happens, these kids or fetus, they are alive while they are in the belly or uterus. The minute you deliver, after a few minutes, they die. Because why? The lung, you don't need lungs while you are fetus. You only need lungs when they are outside. Is that clear, folks? All right. Caused by chronic placental insufficiency and all these things. But the key is parasequence happen when you have oligohydramniosis. Everybody clear, folks? All right. The last thing for today. Let's recap what we did yesterday with those renal questions, right? Which part of the kidney tubules you reabsorb the most water? Answer. I want to answer like this quickly. Those 6 concepts we wrote. Come on. Okay, which part of the place? Okay, very good. Where do you have most concentrated urine on a healthy individual? Don't just say junction. I know what you mean, junction. So it's everybody's like junction, junction. So it's a thin descending and thin ascending, isn't it, folks? All right, good. Which part of the kidney will be most concentrated when they are dehydrated? Whatever C. Some people answer C is the most concentrated urine. And if you see on the bottom, it is C, right? Between junction, right? There you go. Medullary collecting duct is the one that is most concentrated, folks. Okay. Now, which part of the tubules? I want both options. That's the most diluted urine. Most diluted urine. 2 segments I want. Abby, I would appreciate if you type the full words. She's like thick, thin, thick, thin. I was like, what do you want to think? Okay, so it's a thick ascending and DCT, right? Thick ascending and DCT. Which one is influenced by ADH? DCT. Very good. You see, it's not difficult today, right? That's all it is. It's just 6 concepts. Note it down. Look at that. Very good. Now, that's all for today. And tomorrow we will continue. We should be able to finish it, and then we start. We'll see what we start. Okay. All right. See you guys tomorrow.
Thank you.
Thank you.
No problem.